name is Amy Lee, and I'm one of the course directors for the Health Systems and Community course. And I have with me Dr. Paul Lecat, and he has consented to be interviewed to just tell us about some of his perspectives on health systems. So first, Paul, or Dr. Lecat, I'm wondering if you could first introduce yourself and the kind of clinical practice that you have.
Sure. Over the years, I've done all kinds of things. So at the very beginning, just following residency, I practiced in a town of 500, and I stayed there for 4 years in a very small community, about an hour between Buffalo and Rochester. And then I came back to teach. And when I first came back, because I'm boarded in internal medicine and pediatrics, I would do 1 week in internal medicine and 1 week at Children's Hospital. And I would teach in the clinics and be the hospitalist. But when Children's took the teaching out of the clinic, it became difficult, and I didn't want to do the kind of hospitalist practice they had at the time. And I had an invitation from the family medicine group. I always got along well with them, and that allowed me to do both. So I've been at that practice probably for 13 years now, and I really enjoy it because it's a full range of care, and I can add to what they have, and they teach me stuff all the time.
And so you're currently doing clinical practice now and also teaching here at Neomed, it seems.
Yes, and I love the SOAR clinic as well. That's another practice opportunity.
Yes,
So I usually do some volunteer work. Prior to that, I had worked at Faithful Servants in Talmadge, and that was another good clinic. But the SOAR clinic is special.
Super. Tell me how important teamwork is.
Teamwork is everything in medicine. If you try to do something all by yourself without thinking about other people, you will fail. You'll never provide all the needs of a patient, and you'll never be able to provide as much as you could by considering your other resources. That's part of your duty as a primary care doctor, is to make sure that you bring everything to bear on that patient's problems.
So what are some of the components of the teams that you've worked with?
It's so broad. The standard ones, obviously social work, physical therapy, occupational therapy, dietary, spiritual care, dentistry, just trying to think some of the other ones in the community. I mean, sometimes you'll even refer people to stores where they can get different types of food or those sorts of things. So I really try to keep a really broad armamentarium of community resources.
So I'd like to hear a little bit more about that and how you consider the community assets, the community agencies, and any of your contacts in the community as part of your team.
Yeah, so the quarterback of the community resources is generally the social worker. So I rely heavily on my social worker to say, oh, I know somebody over here, or they can get free this over here and free that over there, or we have a card with all the resources and phone numbers. So really, for the most part, the social worker is the biggest liaison with the committee. But I'll give an example. We had a patient who had lost her partner of 35 years. It was very difficult for her, and of course she was grieving, and the residents saw the patient, and the typical results occurred where she was referred to psychiatry and she couldn't get an appointment for 6 weeks. And we both looked at each other and said, this just isn't right. And so I asked the resident to take a spiritual history. It turned out that she was a Baptist Christian, and she was not connected with her church, but she was very open to the idea of talking to the chaplain. So the very same day, about an hour later, we had her speak with the chaplain at the hospital, who was right across the street, and she had a marvelous result. She really appreciated that referral, as opposed to being referred to psychiatry in 6 weeks.
You know, Paul, it's clear that you seem to have a very good relationship with your patients. Tell me how, considering the social needs, how that goes into the decisions that you make on the clinical side as well.
Great question. You always have to assess what somebody's able to do. So coming out of residency training, you know that you have a list of about 20 things that you could do for a given diagnosis. But in the real world, people have limited insurance, no insurance, maybe there's no dental coverage, etc. And so you need to figure out what that person's resources are. So for example, in my small town, if I needed an MRI, I would generally say one of two things. Either, you know what, let's wait on that until this plays out a little further. But if I really needed it quickly, I would say, you need to get your whole family together and pass a hat, and we have an easy payment plan at the hospital. There's a way to get this, but you need this. And so that person, your job as a physician is to let the person know how necessary all these tests are. If you send them out with a scavenger hunt list, they're usually not appreciative. And to be honest with you, especially in primary care, time is on your side, and that you can let things play out a little bit before you throw every test at somebody.
How did you learn all of that? I mean, how did you learn to, I need to consider, not just ordering this test for the patient, and how to really get the health care of that patient met?
Well, it was a bit of a surprise. When I went to my rural community, I had my list of 20 things for a particular diagnosis, and I said, well, Jim...
That's what we teach.
Right? Well, Jim, here are your 20 things that you need. And he says, well, I have $50. And I guess the sad part is these are people that are paying into the system, but they can't afford insurance themselves. And so I feel a burden to try to get them the best care I can at the lowest cost, which involves some risk, obviously, and we share that risk. I tell the patient, this is what by the books you should have, but I'm going to try and get you the things that you need according to the timing and as inexpensively as I can. So I often ask the pharmacist what drugs are on your $4 plan, or some are even less. Generics, about 90% of the time I'm able to prescribe generics with good results. And 10% of the time you need a second level antibiotic or whatever else. But the point is, it was the patient who was honest enough. Not all of them will tell you that they don't have enough money. It's awkward sometimes. But this particular fellow said, well, I have $50. It's like, okay, well, I'd start with these things, and let's see how that goes, and we'll get those results back in a week, and then we'll try again. One of the other disappointing things in practice now is that you must charge a copay. So they can't get by for less than the copay. Whereas in the old days, you could say, well, forget the copay. But anyway.
Well, talking about the old days, you have been in practice for quite a while now.
30 years.
So just, I don't know, maybe the past decade. Tell me about some of the changes that you've seen in the healthcare system that have impacted your practice, and some of the ways that you've needed to adapt.
Well, there are great things that have happened in that we have a bigger palette of options to bear on a patient's problems, but then all of that needs to be coordinated. And so what I've seen is we've moved into an era of less continuity, and the cost of that is not accounted for. So typically, 10 years, maybe 20 years ago, the primary care doctor would see the patient in the hospital and in the clinic, and they knew them, and all that stored knowledge, including what they could afford or what their preferences were, enabled you to make better decisions. Now, there are so many options, and there's so many people who switch every week in the hospital, et cetera, that the patients get confused and feel abandoned. Not only that, but I believe there's more productivity pressure now. So those are the two main changes. The push for productivity and that feeling of, well, my usual doctor's this, but I've only seen him twice. Whereas in the old days, somebody would say, Dr. Smith is my doctor.
Since you're all taking this course, it's a new course, tell me the piece of advice that you really think the student should get out of this course, and as future practicing physicians, something that they really should get that will be of value to them in their future practice.
So I'll give you a general answer, and then something else that I found particularly helpful that isn't generally taught widely. I think the most important thing is to start to develop a strategy to meet patients' needs in general. So what does a physical therapist do? Well, they get your joints working, your muscles stretched, and increase range of motion. So yeah, they also do trigger point injections, and they also do some other things. What does an occupational therapist do? Of course, you'll learn that. You want to make sure that you start to learn how social workers function, and when you can't find a resource for a patient, in my opinion, they're the ones that I would go to first. Secondarily, we always talk about body, mind, and spirit. And we're used to body disease, we're used to mind disease, but spiritual disease is tough too. And I found great resources in terms of a person's spirituality, whatever that is. So it helps to take a spiritual history to see where they're coming from, what resources might be from their faith community to bear on their problems as well. And that's generally neglected.
Interesting. Well, thank you so much.
Thank you, Amy.
I
That was
really
a terrific
appreciate
interview.
your perspectives. And I hope you appreciated what Dr. Lecat also had to say, and we will be talking about many of these issues in the Health Systems and Community course.
Indeed.